Good evening, Dr. G.R. Sharma. Good evening, Pankaj Bhai.
Good evening, sirs.
Good evening, Sharma sir, Gaurang sir, Pankaj sir.
Yes.
ज्ञानेंद्र, हमने टी शर्ट भी सेम पहन रखे क्या?
सर मैं चेंज कर लेता हूँ। अभी last few days the coincidences are growing too much it seems.
Or how was your day?
They're quite good.
Pankaj,
Quite good.
he knows that he'll be here for 2 hours. So he wants to make himself very comfortable.
Yeah, yeah, sir.
Who is answering today?
Myself, Bhushan.
Sir, Dr. Ankit, me.
Okay.
So
Sir,
myself, Dr. Samit.
Sir, Pratik.
Dr. Siddhant.
Sir,
So for today's discussion, Dr. Samit Doshi, Dr. Bhushan Phate, Dr. Pratik Nishar, and Dr. Siddhant Srivastava are answered.
Okay. Good. I'm happy that more students are volunteering to answer. Ankit, you have realized how much improvement is there, and I think if you keep on answering like this, you will head for gold medal.
Thank you, sir.
We wait for 2-3 minutes and start. Dr. Gite has joined. to we start now. Arshim?
Yes, sir. Good evening. Today's case is of an 11-year-old male presenting with complaint of fever since 7 days and right flank pain since 2 weeks.
Hello. Okay, Ankit.
Yes, sir.
Yeah. So now this is a history. How to go about?
Sir, first of all, I would like to elaborate about the chief complaint about the fever. I would like to ask about onset, duration, progression, whether it is associated with any rigor or chills, whether it was relieved by taking any medications or not. Then about the flank pain, its onset, duration, progression, whether it was dull aching or colic in nature, whether it was radiating or not, whether there was any relieving or aggravating factor, any positional variation. Along with, I will ask the history of associated nausea, vomiting, burning, maturation, hematuria, or any lithuria, history of any instrumentation, or history of any trauma in the past, history of lower urinary tract symptoms, history of any constipation, or any history of similar complaints in the past. And if yes, then what was done for that symptoms? Then I will also ask for history of any trauma. That's And also, I will ask about the history of any facial puffiness, lower limb edema, dyspnea. These all things.
Okay. So Bhushan, you want to ask any more questions?
No, sir. Almost all covered, sir.
Pratik?
Sir, antenatal history to the accompanying person if present.
Yes. What else?
And sir, any antenatal history and any postnatal scans have been done. I would also like to have that.
Personally, if you ask me, I won't be interested in that. If the child would have been 1 year old, it would be definitely important. But 11-year-old, you asking about antenatally anything important in the past is good enough. But trying to dig out whether he had antenatal hydronephrosis and other things gives a clue to the examiner that you already know the case.
Yeah. So I think most important thing is you just take antenatal history, maternal history, and whether postnatal any other event which had taken place, plus vaccination and development.
Mhm. Yes.
So when
Yes.
you ask for this sonography and all, that means what Dr. G.R. Sharma is saying is right. That means probably you know what is the case.
Acha, Ankit, one question.
Yes, sir.
This particular slide, it mentions two symptoms.
Yes, sir.
What is wrong in this particular slide?
Sir, sequencing, right flank
Yes.
pain.
Very good. Very good. It's the right flank pain which should come first and fever comes second.
Right. Okay. So just show Shiv.
The patient was relatively asymptomatic about 2 weeks ago when he started experiencing dull aching pain in the right flank. Pain was insidious in onset, gradually increasing in intensity, intermittent, and radiating towards the right groin. For the past 7 days, he has developed fever, which is high grade, associated with chills and rigors, relieved temporarily by antipyretics, and there is no diurnal variation.
Okay, go ahead.
There is no history of any other abdominal pain, dysuria, lithuria, pyuria, urgency, incontinence, urinary retention, no previous instrumentation or catheterization, no nausea, vomiting, no jaundice, facial puffiness, exertional breathless, lower limb edema, backache or bony pain, no bleeding disorders, anticoagulant therapy, blood therapy, no radiation or chemotherapy.
Finish the history.
Please do not talk of all this
Patient,
in an 11-year-old child. See,
yes,
please go back one slide. To talk of radiation, chemotherapy, probably is completely out of place in this patient. What do you say, Phil Ganadhar?
Yeah. See, that has been put up because you are thinking in terms whether he has had been treated for Wilms tumor, which should not be the first thought that comes. Otherwise, they would have already said he has had so many things. So it doesn't come in the presenting symptoms any which way or
You
present
see, a lot
history,
of
history of
things which,
present illness.
remember that PU junction obstruction, even if it comes as a case, it will come as a short case. So try to get out of history and clinical examination as early as possible. A lot of things can put you in difficult situation. Like examiner may just stop at radiation and chemo and keep on discussing that. Okay. Again, in a small child to really talk about instrumentation and is probably not needed. Probably not needed. Anyway, you and important thing is that you make a note of all this, but talk only what is important.
A better way would be there is no other specific complaints pertaining to any urological symptoms or GI symptoms. And if the says ki what else, what you have asked, then you can elaborate on everything.
Absolutely.
Otherwise, what happens? It goes towards right loin pain, fever, and facial puffiness. What is your DD? Then you go towards glomerulonephritis. What are the different types? See, examiner is not going to answer, but if he is not in a good mood, he will keep on answering what are types of glomerulonephritis, which is unnecessarily going on a track which you don't want to go.
What we also notice in exams, sir, that we being examiners, that we already know that five students are coming and presenting. So by second or third case, second or third student, we already know what is the history, what is the examination. And
Yes.
then when you come and talk something like this, na, then it irritates the examiner and the examiner thinks you're acting over smart. फिर गड़बड़ हो जाता है.
No,
So by
it can
second
more
or
than
third,
irritate. What happens is, I'll tell you that already with three people you have discussed
yes, sir,
PUJO
that's what I'm
and
saying. Yes,
pyeloplasty.
yes, sir.
Now, if somebody wants to talk about radiation, I would
Correct, sir.
change the track and discuss radiation.
Right, sir.
ठीक है so ठीक है जी
I
चलिए
think
बढ़िया
what Pankaj sir has said is the bottom line that you should differentiate whether it is a short case or a long case. In a long case, you mention the detailed history of presenting illness. In the short case, you elaborate on the symptoms and mention the other things in brief and go ahead.
I have one question here.
good
Sir, usually in case chief complaint when there is a flying pain history, we in stone disease, we never ask about detailed crisis. So is it so how whether we should elicit the history of detailed crisis or not?
You should elicit, but while mentioning, you mentioned there has been no specific aggravating or relieving factors. Now, if they ask you what are the possibilities of aggravating or relieving factors, then you can mention this as one of the possibilities.
and look at it from this point of view in a 11-year-old child what is the
Yes.
possibility of there being a diuretic episode causing pain
No, sir, I am just asking in general whether if the
yes
patient is if
so
it is
in
30,
this
40 year
particular
old.
patient now in contrast you give me a 20-year-old boy who presents with such pain I may be accepting that's a time a child may experiment with alcohol and there is a likelihood of Dietl's crisis. But a 11-year-old child, there are very few reasons for diuresis and causing Dietl's crisis. Okay.
Sir, if he has been presenting with a palpable lump, then
That changes the scenario completely. Okay. So a patient, you see, everything will depend on what your presenting complaints are.
yes,
Flank pain and fever. Do you keep PU junction obstruction as a first diagnosis.
No, sir.
Okay, it
No,
will
sir.
be there in the list, but probably not the first diagnosis. Okay,
Yes.
one problem with this class is that the students know the diagnosis. Okay, so that is how then we start thinking of things in this fashion. Otherwise, imagine a patient coming in OPD, 10-year-old child with flank pain and fever. Where will you go at Detail's crisis in that patient? There is no question of going there.
Yes.
So there I would have asked for, means right flank pain with fever. My first thought will go towards VUR. Okay. Or probably pyelonephritis or something else. PUJ will be there, but before that, probably stone will come before PUJ. So
Again, it
that
depends on where your examination is.
Sir, actually, this happened to
Examination
me.
center.
Sir, this happened actually during my formative assessment practical. So that's why I have asked. The same case was there in my formative assessment. I was asked you whether you haven't asked about detailed crisis. So that's why I have asked.
So you see, when you get that 20, 30 minutes or 15 minutes, whatever time you get, you ask about everything, but don't talk about it. अंकित एक चीज ख्याल रखिए, आपका स्कोरिंग और जो इम्प्रेसिंग द एग्जामिनर होगा वो इवैल्यूएशन और ट्रीटमेंट में होगा, हिस्ट्री में नहीं होगा। हिस्ट्री में सिर्फ तकलीफ होगी, ठीक है। यू
जी।
गोइंग ऑफ समथिंग इन हिस्ट्री विल बी हेल्ड सीरियसली अगेंस्ट यू।
हेलो
Okay, sir.
मैं होस्ट नहीं बन पाया, मतलब दिख नहीं रहा हूँ, को होस्ट नहीं हूँ, तो उसी के लिए मतलब मेरे को स्लाइड दिख रहा है
यू आर
लेकिन
ऑडिबल, प्लीज क्लोज योर ऑडियो। Okay, so the aim should be to come out of history as soon as you can.
जी
ठीक है। See,
जी sir.
it is very easy to defend and talk about evaluation and treatment, but very easy to slip in history and clinical examination. ठीक है,
जी sir.
चलिए आगे बढ़े सर।
The
Gaurang,
patient
you agree
was
ना?
full
आपको
term.
क्या लगता है?
Yeah, fully, sir.
Patient was a full-term normal vaginal delivery patient with no known antenatal USG abnormalities or postnatal events and normal milestones as per age. No history of poor growth, developmental delay, recurrent febrile illness, or failure to thrive. And past history, family history is not significant. The personal history also is not significant. Everything is normal and regular bowel bladder habits.
Okay.
In
So
general
fine.
condition,
Now let us ask them. So after that, yes, Ankit, what now you want to know the history?
Sir, nothing much, sir. मतलब immunization, I actually immunization history and developmental milestone. That's it. Not.
Okay. So Pratik, now looking at the history, he's an 11-year-old boy. What do you think? What are the possibilities? Which are the different cases you have seen in your OPD?
Sir, it may be because of VUR which would be present, or maybe because of, firstly, it would be because of any infective pathology. So, would go in that direction, such as a VUR or a pyelonephritis or a PU or a stone disease.
Pratik, I think a better way to answer would be, with this history, my suspicion is that of right-sided pyelonephritis, and I would like to evaluate him further to look at the various causes of pyelonephritis. Because what happens, you mentioned reflux presenting as pyelonephritis would be much earlier in the childhood, and now the history says that there has been nothing in particular in the past. So again, why reflux should present with pyelonephritis at this particular stage at 11 years? So it could be a congenital pathology, or it could be an obstructive pathology in the form of a stone disease, or rarely it could be some sort of a functional urinary problems that have crept in over a period of time that has resulted in infection. So this is the way of playing around words and getting ahead with the story.
So Pratik, what are the possible now looking at this? The diagnosis that Dr. D.R. Sharma said, yes, I agree with him. But what are the conditions that come to your mind?
Sir, first of all, it would be any calculus disease of the right side associated with infection. Second, it could be because of any other like, obstructive lesion such as PUJ obstruction or a mega ureter or other such benign lesion causing obstruction and associated infection and fever.
Okay, Samit, can you just tell us how you will put it after
Sir,
listening to both of them? See, what is important is we are trying to tell you that how to summarize the case, go very fast, and you should be knowing how to present it so
sir,
that,
first,
further questions are not asked.
yes, so first, according to the symptomatology, it could be a right-sided stone disease with concomitant infection, pyelonephritis. Then it could be secondary to any lower PUJO obstruction and then leading to a pyelonephritis. Then it could be any cystic disease which got acutely infected, can lead to that infection.
Okay.
And uh, so then it could be adult the PUJ obstruction with pyelonephritis or pyonephrosis.
Okay. Yeah. Can you just help them out how to summarize, and in case if they are asked, so what are the probable differential diagnoses, then how to go about?
I think they have mentioned it. I would put it this way: कि a patient with right-sided flank pain and fever. My first diagnosis is pyelonephritis, and I will look into what can cause it at this particular age. It could be a stone disease, it could be a congenital pathology, or very rarely it could be a cystic disease, which is a large cyst which has caused infection, which is basically quite rare, not so common at this particular point of time.
Yes.
Fine. So, Samit, now what next? You know the history. Now, what you want?
So then I would like to examine the patient, sir.
Okay, fine. Harshit?
Systemic exam.
Sir,
Yeah, show
in
them.
general examination, the patient presented with a temperature of 100.2 and pulse of 100 beats per minute, and patient's weight was 30 kgs. Otherwise, in per abdominal examination, there was no specific finding. Patient was uncircumcised, and on palpation also no lump was palpable. Neither no significant findings in rectal examination as well.
Okay. So, Bhushan, why you
Yes,
want
sir.
to do per rectal examination? And how will you do per rectal examination?
Sir, in the like male the child, sir, we will do the rectal examination in Sims position with the little finger, sir. With like after application of the jelly, we will like strike at the 6 o'clock, and we will do the rectal examination. Uh, in rectal examination, we will get to know whether like anal tone is normal or not. And like if it is lax, then it can give just idea of any like it for like incontinence, like regarding if incontinence is there, then it will suggest that it can be due to that also.
Sir, any
Anything
neurogenic
else?
bladder involvement?
One is a neurogenic bladder. You want to
Yes,
rule out. Second,
yes.
Hard stools can show constipation.
Impaction.
anything else? I'm just asking you because in per children you are asking for a colorectal examination, that must be something in your mind. Na? So what are the other diseases that you get? Like
Sir, any large ectopic ureter or
That is not palpable correctly. No.
any midline cyst?
Yes, a large prostatic utricle might be palpable. But these are far-fetched
yes,
things. These are not common things. You harp on the common
not
things.
common. Yes, I agree with you. But when they are saying it, they should be ready with an answer. So what are the congenital anomaly which can, be diagnosed by colorectal examination or can be suspected?
PUJ is sometimes associated with the imperforated anus, so it can be like when you are doing colorectal examination, you get to know it's
Vaginal
imperforated
lavage,
anus.
no. The rarest of rare possibility would be an accessory urethra.
See, if bad luckily you get trapped with such a question, the best way to come out of it is say that, sir, finding any pathology in this patient is very unusual. I have done it for completion of clinical examination. Okay. And
Yes.
still, if they push you in what are you likely to find, then you can talk of, say, neurogenic bladder or whatever else you want to talk about. But best is to come out of this situation saying that ठीक है, completion of examination के लिए हमने देख लिया, वैसे I don't expect to find anything wrong.
Amit, ne? Huh.
Gaurang bhai, Dr. Gite has joined, so he could also be made the host.
Yeah.
Okay, so we seem to have completed the examination. Now, what is the thought at this time? Any change in the thought, or how do we proceed?
We'd like to do ultrasound abdomen pelvis of the.
so first the routine blood investigation, CBC, RFT, along with urine routine and culture, and then extension of the clinical examination, including an ultrasonography of abdomen pelvis with the post-void residue.
Okay. Right.
बताइए सर.
Yeah. Harshu, go ahead. So now, Siddhant, you are there?
Yes, sir.
Now you just see all the reports. What are the things you will like to know? See the report and tell us.
Sir, I would like to do basic investigations, these blood reports. The counts are on the higher side, 13,600. And I would also like to know the blood sugar levels of this patient, sir. And also would like
Anything else? In this blood report, anything else is little
So creatinine.
abnormal?
Done.
Okay. Why? Why 0.99 is not normal? Siddhant, what do you think?
so it's within the normal limits only, sir. The counts are on the higher side, the
Counts.
on the higher side. I would also like to know the blood sugar level, sir. And
See, the creatinine level is different for adults and for children.
Yes, sir.
So you should always know what are the, in this particular laboratory, what are the limits for the children also.
yes.
And for children, 0.99 is definitely is high.
Okay, sir.
Yes.
Okay. Then CRP is also raised. Okay. What else you want to know, Siddhant?
So blood sugar levels and urine routine microscopy, sir.
Why you want to know blood sugar?
Uh, so as the patient is also having fever, it is mandatory from our side to rule out any metabolic disease. So just a basic workup. I would also like to know blood sugar and urine routines.
Okay, so this is the urine routine.
It shows the pus cells are there 6 to 7 and plus the patient is also having fever, urine culture sensitivity along with urine routine and as extension of my examination, I would like to do sonography, sir. A USG A plus B, sir.
Now this is a report. If you have to use antibiotic, what antibiotic you will use?
Third generation cephalosporin, sir.
Be specific. Which antibiotic, what dose?
So cefixime can be.
You are there as a consultant. The patient has come to you with this report. You have to write a prescription. Which antibiotic, what dose?
So cefixime 500 mg, sir.
Cefixime, how much?
Those I'm not sure, sir. That
Anybody knowing the dose of cefixime?
Any Ankit?
Sir, dose of the dose of, I would like to give amoxiclav in this patient, and the dose of rifaximin is 8 milligram per kilogram per body weight per day, sir. And amoxiclav is 5 milligram per kilogram per day.
So now just I want to know, this is a complicated urinary tract infection or uncomplicated?
Complicated.
So Pratik, then tell us what is complicated and what is uncomplicated, and what is the difference in the management?
Uncomplicated UTI is, sir, a non-pregnant female patient having a urinary tract infection without any anatomical abnormalities, without the urinary tract without any anatomical abnormalities.
Good. And complicated, what are the criteria? What are the different types? I mean, what are the different things?
Any anatomical abnormality.
Anatomical abnormality, pregnant female, child with UTI, male patient,
Patient with UTI.
Then
and associated pathologies if present, maybe because of stone prostate or any other thing.
Yeah.
what else?
A simpler way would be a complicated UTI is a UTI which is associated with structural or functional abnormalities of the urinary tract which interfere with the eradication of the bacteria. Right? So that encompasses everything. It could be a structural, that is an anatomical or a functional abnormality. And anything which doesn't encompass this is an uncomplicated UTI.
So now this is complicated or uncomplicated?
Complicated UTI.
So in the
The
complicated
present status
UTI,
of these terms, complicated and uncomplicated. As per the newer guideline, the EAU guideline specifically, they have dropped the terms complicated and uncomplicated. Now they talk of localized and systemic. So any
Okay.
patient presenting with fever or clinical or pathological signs of infection becomes a systemic infection. So this would qualify as a systemic infection. So complicated and complicated is still a term used by EAU guidelines because they have not updated it for a long time. But EAU, which got updated in 2025, they have now dropped these terms and changed it to localized and systemic.
Okay. Thank you, Pankaj. So now in this, like, what type of medicine you like to use? So always go for a higher molecule. Correct. So when you are sitting in a OPD and the patient like this comes, you will not like to use the
I will
primary
give you,
generators.
there are three drugs. Leave aside this culture report. There are three drugs to which it is quite sensitive: nitrofurantoin, amoxicillin, and cefixime. Which is the drug which you will prefer in this patient?
Amoxicillin is resistant.
No,
No,
Oh,
no.
sorry, nitrofuran. Okay.
Sir is giving an example. Let's
Example.
presume that these are three positive, these are three sensitive antibiotics. So which
Okay,
will you choose?
bring it down to two. There are two drugs to which it is sensitive: nitrofurantoin and cefixime. Which one will
Uh,
you use?
Cefixime, sir, because
Fix.
it is all because it has got penetration into the renal parenchyma also.
Yes, very good.
Fine. Okay. So we will use a higher molecule and your strategy. Fine. Harshu, go ahead.
अरे रह गया यार डोज ऑफ सेफिक्सिम
8
8
Yes,
milligram,
milligram per
Cefixime.
8
kg.
8
8 to 10
milligram.
milligram per kg per day.
Yes, sir.
So he is 30 kg. Take it 10, 300 milligram. How will you give it?
So two divided doses.
See, basically, when an examiner asks you these things, he wants to know whether you have prescribed these medicines and you are aware in what doses are they available. Obviously, in a 11-year-old, you will not be giving a syrup, you will be giving a tablet. So, what is the dose in which the tablet is available?
200 milligrams, 200 and
200.
400.
200,
200
100, and
and
400.
400. 400.
Right. So, you should be aware of these things and how you will give it. Okay, let's go to sonography.
Bhushan?
This is a sonographic image of the abdomen and pelvis where bladder is distended along with the thickness in the bladder is noted. Bladder wall thickness is noted. Left-sided kidney is normal with normal cortex and parenchyma. Left-sided kidney pelvic system dilated is been seen. Uh, yes, sir. Ureter is not seen in this given image, sir.
Something more about the dilatation that you can mention on this report.
Sir, anterior posterior pelvic diameter we can measure from this, sir.
That is true. Anything else?
So about the parenchyma,
Parenchyma
the
is
thinning
also
out
thin,
of
sir.
the
Thinning of the
parenchyma.
parenchyma is noted.
The parenchymal thickness, the
Yes,
parenchymal
sir.
Parenchyma
appearance, the
appearance.
echogenicity, the
Yes.
dilatation of the calyces, the dilatation of the pelvis.
Yes.
So there are
Yes.
these 6, 7 criteria that you need to always look for, or if it is not mentioned, ask for when you are getting a sonography report. So,
Okay. So the most important thing is what G.R. Sharma has said is, first of all, you should find out if there are solid organs, just say whether they are normal or not. Okay, then a kidney, ureter, and bladder. And in the kidney, you will look for the parenchyma, you will look for any hydronephrosis, right? Any stone or any mass. If you can see whether ureter is seen, dilated, not dilated, or not visualized, and come to the bladder, whether it is filled up, the wall thickness, everything is fine. Prostate, if you can see, then you comment it, right?
can you
Yes.
And
mention the degree of
on the
grade of
top of that,
hydronephrosis in this?
yeah,
Sir, it is
and
grade 4
also,
SFU.
yeah.
So if you have mentioned
And
grade
one
for
more thing I
SFU,
want to tell you is talk about the signs. There are different signs which are seen on radiology.
Yes.
what are the different grades on SFU?
Sir, it starts from 0 to 4. 0 is normal. 1 is slight splitting. 2, there is dilatation of the pelvis with the major. 3 is with minor without parenchyma thinning. 4, minor with parenchyma thinning.
But somebody was mentioning about the AP diameter. AP diameter does not come into picture in the SFU grading at all.
AP
So,
diameter, then we have to
Unitract dilatation in that classification,
UTD
epidemical one.
dilatation, sir.
right. So, what are the various ways in which hydronephrosis is graded on sonography?
So one is UTD classification. The second one is anterior posterior renal pelvic diameter. Third one is Owen's classification. Fourth one is the SFU classification, sir.
There are two more classifications. One is modified Onen and the other is the radiological classification.
Okay.
So you should, if you have mentioned all these names, that is excellent. What is commonly looked at it is the UTD classification.
Yes, sir.
Right.
Okay. So what next now?
Harsh, show them the report.
Sir, the ultrasound report shows that left kidney and left kidney is normal in size. On the right side, kidney is 12.2 by 5.6 centimeter with gross hydronephrosis and abrupt cutoff at PUJ with dense echos within, with irregular bladder wall with wall thickness of 5.2 mm.
What are the things this report does not mention?
It's about the ureter
The post-void residue
and
and pre-void.
starts from the kidney. It does not mention the anteroposterior diameter. Secondly, it does not give you any indication about what is the parenchymal thickness, its echogenicity, whether there is central calyceal dilatation or peripheral calyceal dilatation associated. Then no mention is made about the ureter, and also you have rightly said that the prevoid and postvoid is not mentioned. So in your practice, you stick to a sonologist who is sensible, make them understand that these are the things you want to know from them, and always ask for these things. So once it becomes a habit on their part, also you will get those reports. Otherwise, somebody's moderate hydronephrosis is the third person's gross hydronephrosis, and somebody says mild to moderate. So that has no meaning whatsoever. Okay, so Samit, can you sum up whatever is there at this point of time?
So starting from the symptomatology, based on that, the patient is having fever with right flying pain, and on investigations, the on examination was normal. On routine laboratory investigation, TLC was elevated to 13,600 with elevated creatinine of 0.9. Urine routine showed slightly raised pus cells of 7. Urine culture was positive, and on sonography, as per the report, there is right-sided gross hydronephrosis with cutoff at the PUJ with dense echoes within it, suspected to be right-sided PUJ obstruction with infection in it.
Okay. So now what would you do?
So, Bhushan, I have one question to you.
Yes.
Suppose he is a young child.
Yes.
Okay.
Yes.
And in that case, you want to know about the antenatal ultrasonography.
Yes.
What are the different things you'll ask for?
So, the thing, same things are anterior posterior renal pelvic diameter, then the cortex, the thickness of the cortex and medulla, like parenchymal thickness, corticomedullary differentiation, the diameter of the ureter, whether the dilatation of the ureter is still the bladder or not, bladder thickness. Yes, sir, all these parameters, sir.
See, when an examiner asks you this question, he wants to know that what are the points in the UTD classification that you are keen to know on a sonography.
So
Everything you say, the size of the kidney, the parenchymal thickness, the parenchymal hypogenicity, the AP diameter, whether there is central or peripheral calyceal dilatation, the status of the ureter, any ureteric abnormalities in the form of ureterocele, and the bladder abnormalities. All
Sir,
these.
even any history of oligohydroamnios?
Yes.
Yes. So when you get opposite of that, in which disease? Polyhydramnios.
Mm.
In the renal case. So when we were discussing, one of the residents, he told us that in some of the conditions of polycystic and atrophic kidney, you come across this. So you just find out. I could not find out. Okay, so there is one condition where you'll get it,
Okay.
like renal agenesis or whatever it is. Just fine. Okay, so now, Samit, this is a case. What you want to know? Any other investigations you want to do?
Before
Sir,
investigation, now this child is in front of you with all these investigations. What will you do now?
sir, I will admit the child
Hmm.
and then start with antibiotic and plan for decompressing the system, sir.
So you have started the child on antibiotics. He has been started on cefixime, right?
Yes, sir.
So now today on Wednesday you have seen him. You have started him on cefixime. You said you will put him. You will go for decompression. So you will immediately decompress today. You will decompress him on Thursday, or you will wait till Friday, Saturday.
Sir, as the child is there is play pain symptomatic and there is systemic symptoms also, fever under antibiotic cover. There are dense echoes also which are mentioned in the ultrasonography. So better would be to go for immediate decompressions.
The radiologist has mentioned dense echoes. There is no classification which says you can objectively classify echoes into different types. So if I am there, I would start the child on antibiotics. See, he is not very sick at present. The temperature is just 100. Counts are just 13,000. They are not too high. He has not received antibiotics so far. So it is infective hydronephrosis which may resolve or which may go towards pyonephrosis. Pyonephrosis definitely becomes an indication for decompression. But
yes,
my priority would be start him on antibiotics. Yes, I would admit the child to keep him under observation and look for whether he is showing signs of improvement or there are signs of deterioration. And with under cover of antibiotics, if he is taking everything orally and he is being able to maintain good hydration, I would put him on oral antibiotics. But if his intake is poor, he is unlikely to take antibiotics properly on time, then I would prefer injectable antibiotics and see over the next 48 hours what is the improvement.
okay.
Whether his symptoms subside, his fever subsides, whether his renal angle tenderness subsides, his tachycardia subsides. So I would look at all those aspects and then take a call whether I should go for decompression or not. Because see, when you are mentioning it is a dense echoes or something of that type, you have already thought in terms of pyonephrosis. And if you are talking in terms of decompression in pyonephrosis, you will have to put your foot and say it is, I would put a nephrostomy.
Yes.
And a nephrostomy in a child is easier to say, difficult to maintain by the
Yes.
child and for the parents. Practically, it is a tough call on their for them. Gaurang sir,
Yes.
Pankaj bhai, any other thoughts about this?
So I agree with your point that we have to wait for at least 48 hours once because the child is really not that sick for immediate decompression. But I would feel, Gyanendra, that if I have to decompress this child, I would prefer a PCN over a digest child.
Yes, sir. When it comes to decompression, PCN,
Yes.
but not
So,
primarily
Pankaj,
DPAP.
I wanted to ask that question to all of them,
Yes.
what they will like to do. So, Samit, Pratik, Bhushan,
Yes.
and Siddhant, you tell us. Let us start with Siddhant. Siddhant, what you will do? Suppose after 48 hours, patient is not responding, he has become toxic, and you want to drain. What you will like to do?
Sir, I would like to do put a nephrostomy tube, sir. As the patient is not improving on antibiotics and the patient is becoming toxic, it is necessary to decompress the system. So in that condition, I would prefer putting a PCN, sir.
नहीं
Why PCN and why not digestant?
शर्मा सर,
So
Yes,
for
sir.
doing
अगर पेशेंट का टीएलसी ऑलरेडी बड़े वाला है, इंटरनल ग्लूकोज अगर किडनी में है,
हाँ,
तो एंटीबायोटिक देके उसको डिटोरेट होने तक या फिर 48 आवर 72 आवर क्यों वेट करना है डिकम्प्रेशन नहीं करते हुए? एनी अदर ऑप्शन?
sir,
अगर
see,
अर्ली फेज में किया तो व्हाट आर द प्रॉब्लम्स यू फील?
नहीं, sir, the other way thinking is कि this is one school of thought कि you decompress it immediately. But very often these
Because
children,
why I am telling, because if system is obstructed and infected, so in spite of waiting for the result of antibiotic, it is a vicious cycle. आपने अगर obstruction relieve नहीं किया तो antibiotic काम नहीं करेगा. Antibiotic काम जो obstruct करेंगे तो it will be work more ना.
नहीं sir, I say कि what you are saying theoretically is right, but if you see these patients, they come with infection and you give them antibiotics, more often than not they respond to it and they are afebrile, they are much better. So a procedure is avoided.
सर इन्फेक्टेड हाइड्रोनेफ्रोसिस वर्सेस पायोनेफ्रोसिस का ये कंसेप्ट है एक्चुअली. इफ इट इज रियली पायोनेफ्रोसिस विथ इंटरनल लिकोज एंड रेज्ड टीएलसी, व्हाई टू वेट फॉर द डिकम्प्रेशन? दैट्स व्हाट आई एम टेलिंग.
Looking at the entire picture, I won't agree with the diagnosis of pyonephrosis. I will give you my reasons. Uh, he is not running very high grade fever. His pulse rate is just 100. His temperature is just 100. Counts of 13,000 are not very high for this particular child. So, and the
And no renal
CRP is only
tenderness.
8. And CRP is only 8.
And no renal tenderness.
Yes.
So, Dr. Gite, I think as a student or even in practice, I would take a midway. I would start with antibiotics and see how things move.
Yes.
If child is
That's
moving
why I
good,
said I
I'll
would
continue
admit
with
and then look
antibiotics.
at it.
Yes, but and there will be no hard and fast 48 hours. If things
Yes.
are not improving, you can always intervene anytime.
ओके, थैंक यू सर.
नहीं सर,
So
आपकी
basically, I will tell
थॉट अलग
you,
हो तो बोलिए सर.
नहीं, Pankaj,
हाँ जी.
basically we have to tell students that if you are talking of this is pyonephrosis, then talk of draining. If you are
Absolutely.
talking of infected hydronephrosis without toxicity, you can talk of antibiotics as well as drainage, right? So my just question is, why you want to do PCN and why not to do degestanting?
So if it is suspected pyonephrosis, then thick pus would drain well from PCN rather than a stent. Stent might get blocked. And we also come to know about the functioning, the daily output uh, uh, once the infection is subsided. So on the how much is the kidney pouring from that side?
What French nephrostomy will you put?
Yes, Siddhant, answer.
It,
sir, 10 to 12 French nephrostomy.
You just
10
mentioned
to
you are thinking of draining thick pus with 10
thick
French
pus and 10 to 12.
So as it is, yes, sir, 12 to 14 French would be ideal, sir. In this case, to drain the pus, if there is pyonephrosis, it would be better.
Yes. So always a bigger size.
yes, sir.
See, a
Don't
simpler
go,
rule of thumb that I
don't be
follow,
conservative.
and Pankaj can add to it, कि when you put a 18 gauge needle and you aspirate and you look at what is the type of fluid that is coming out, If it is a turbid urine, even a 12 French would do. But if it is a thick pus, then definitely a larger bore nephrostomy is needed.
Hello.
Fine. And how will you do? Siddhant, how will you do PCN?
Sir, usually it is done under local anesthesia, but as this is a
He
child,
is 11 years old.
yes, as this is a child, I would like to do under anesthesia, sir. First, general anesthesia, sir. First, I would do preliminary sonography and put the patient in prone position. I would like to mark after doing sonography, I would like to mark the most dependent calyx, and then I will puncture it. And based on the output, if it is a turbid urine or pyonephrosis, I would put in a guide wire, and then I would, and on the basis of the output, whether it is a turbid urine or a pus, I would like to put I would sequentially dilate it and then put a Malicot catheter, sir. And even that PCN would help to decompress, as well as it will tell me the output also. So it will tell me the function of the kidney also. So that is also a better thing.
One more thing can you do? Any one of you?
Sir, after
if
we can do an nephrostomogram from the PC
Yeah.
for the anatomical to look for the anatomy. So that is also a better thing. From the PCN, we can do antegrade studies.
Sir,
Okay.
just one small addition. I had a
Hmm.
similar case in my DNB exam at PGI Chandigarh. And I was asked exactly this question by my examiner ki you have put a nephrostomy and then would you do a nephrostogram? And I had said ki I will not do a nephrostogram at this point of time. My primary
It
objective
is
is to
not
drain.
now, later on.
Later on,
Later on.
yes,
We are
not
talking
now.
of later on.
Yes, yes.
Hello, Dr. Gaurang.
Yeah.
See, I'm Dr. Chaudhary from Nagpur. Can
Yeah.
I ask a question or I just listen?
Yes, no. Please ask. Please ask.
Thank you so much. No, in the context of discussion between the infected hydronephrosis and pyonephrosis, and we are still managing the patient on the CBC, urine culture, and ultrasound. Can some additional investigation be done to make a concrete diagnosis whether we are dealing with pyo or infected hydronephrosis still further?
Sir, like
So, sir, primarily the infected hydronephrosis versus pyonephrosis is diagnosed with ultrasound, that is with internal glucose. Thick pus can be diagnosed with ultrasound. If it is not responding and that pyonephrosis, if you want to rule out causing some uh, problems in the parenchyma like abscesses or parenchymal destruction, if you are suspecting like this, then there is a roll-up CT scan. Otherwise, whatever we are doing at this juncture is okay. That's what I feel.
sir, I strongly am a person who believes that CT scan should be avoided as much as possible in children.
That is another defense. But in spite of, if you are considering the some destruction, parenchymal destruction, to
So
rule
if you
out
look
that
at,
multiple
yeah,
abscesses,
at infant,
cavities, that
yes, yes,
at that situation, CT is okay. It may be adult, probably maybe child. But another defense, what you are told is CT scan should be avoided. These are the two defenses. And pyonephrosis is definitely diagnosed with sonography.
yes,
Only pyonephrosis.
yeah. And if you look at the ultrasound picture, the parenchyma is thinned out, but it looks quite good. It is not showing any,
So,
So one can proceed with the
yeah.
PCM, the ultrasound only.
yes.
Okay.
Okay, so now there
So,
are two possibilities. One is that the child is admitted on Wednesday, but by Thursday he is showing high grade fever and you have decided to go with nephrostomy. The second possibility is that you have started him on antibiotics and next day morning he is fine, he is afebrile and he is having good intake, good output. So what would be your plan of action in this scenario?
yeah. But Gyanendra, Dr. Chaudhary, I'll just telling Dr. Chaudhary,
Yeah.
now there are two scenarios. One scenario in this case, we have got infection. But suppose if there is no infection, na, Dr. G.R. Sharma is telling that is right in exams, in the children, they should not talk of CT scan. So that is very simple. So if there is no infection, this goes very smoothly. That they do ultrasonography, then they do other tests to find out their diagnosis, and then the management. But here we have interrupted because patient has infection, and that is why it has been little diverted towards that. Yes, when child comes with an infection, then immediately what we will do. And as Dr. Gite said very rightly, after doing this, because we have to treat the child immediately, and after doing that, now we will decide what we want to do. So if you are suspecting that there is some anatomical problem, there is a pyelonephritis or there are abscess formation, in this case, then you'll do CT scan. Otherwise, in children, there is no role of CT scan.
Sir, I would like to add something, sir. Like you said, when indicated, CT can be done. Also, sir, in today's day and time, CT has changed a lot. Like at SEFI, sir, we are doing pediatric CT protocol, which is
Mm.
quite safe, and they're almost giving radiation less than X-ray also. So, in very deserving cases, it can be done with the
Yeah, you can
pediatric
go ahead.
CT.
Yeah.
Sir, that may not be the rule, and in exam, the CT should be avoided in pediatric patients.
Correct, sir. That we agreed, sir. We are just saying that when required, it can be
Yeah.
done.
And it
Yeah.
is very rarely required.
Yes.
Dr. Chaudhary, if you have got any suggestion or any question, you can ask. Otherwise, we'll go ahead.
Yeah, please go ahead. Yeah.
Okay, fine. Okay. So
Okay.
now just let us know what next.
Yeah, Siddhant. Wednesday
Yes,
admit किया
Siddhant, this
Thursday the
patient has
child is
absolutely
afebrile or
improved.
symptomatic.
Yeah, Dr. Ganesh Sharma said, he has got only infection. It was not a pyelonephrosis, and he has improved with the medicine. Now what you want to do?
So if the patient has improved on medicine, if his vitals are stable, his counts have decreased, and then I would like to monitor the patient on antibiotic only, and then for noting the function of the kidney, I would like to go ahead and do a nuclear scan, sir.
When will you do a renogram?
Sir, after the so first I will like to confirm after the whole antibiotic cover has been given.
So what is whole antibiotic cover?
Sir, sir, after 5 to 7 days, after 1 week, and I would like to repeat a urine culture after 5 to 7 after 1 week. I would like to do again a CBC, a routine culture. If it does not show any pus cells or if the count has decreased, if the patient is vitally stable, then I would like to go ahead and do a diuretic renogram study.
Siddhant, see, this is all good when we talk in terms because these are general terms in which we are talking. The first dictum, he has pyelonephritis, that is certain.
Yes.
So when there is pyelonephritis, how long should an antibiotic be given? When there is cystitis, how long an antibiotic should be given? And when there is pyelonephritis, how long an antibiotic should be given?
So cystitis would be 3 to 5 days.
In a
Female.
child, female or male?
Female.
So here we are having a male child.
So 1 week of antibiotic covers.
Yeah. So any child who is having an infective hydronephrosis, I would give him at least 10 to 14 days of antibiotics. Okay, suppose you want to do a renogram, what is the harm in doing it earlier? क्या problem आएगा?
If we are doing an infection, the background activity will be more.
So
the false this thing differential function will be seen.
high or low?
Infection higher, background activity will be there.
So it will show a higher function.
Yes, sir.
So if at all you end up doing a renogram in a patient who has got a stone disease with infection and it has been done, so it will show a higher function or a lower function. Infection, see, background activity is one, but what about the renal function per se? Will it be go high or will it be low? Have you ever seen an IVU done in a patient with pyelonephritis? Hmm. See, infection per se will affect the functioning. So the function will be erroneously low. This background activity and other things there are, say, if you go for a let's come to the radionuclide part and then we will discuss it further. Okay, so a safer, according to me, a safer answer would be, and I would give the child antibiotics for 10 to 14 days, confirm that the infection has been eradicated or brought under control by looking at his subjective improvement, clinical parameters, and confirm it by the same by doing certain biochemical tests like CBC, urine, and CRP. And I would also ask for a repeat urine culture. Yes, fine.
So I had one doubt.
Sure.
If we are managing patient on oral antibiotic cover and
Yes.
if he's not responding or the
Hmm.
signs of responding are not that much, so should we straight away like go for decompression or switch to any other IV antibiotic and then wait and then
In exam, either which way you can answer and defend it. You ask me practically, the approach is a child who is able to take things orally, we stick to oral antibiotics. Otherwise, you straight away start with injectable antibiotics and assess over a period of time. That is
okay,
in a day or two.
okay, sir.
Yeah. So now the child after 10 to 14 days is perfectly fine. What next?
So then the functional evaluation nuclear scans
Specify
and
what
so
type of study you want.
so
Ethylene
EC or a
distinction.
MAC3.
EC or MAC3.
What is the full form of EC?
Ethylene
Ethylene
distinction.
dicysteine.
Right. What is the difference between EC or MAC3 versus DTPA?
So DTPA will give breed a result about the GFR and it is purely by glomerular filtration. And EC and MAC3 are tubular fixative mainly by tubular secretion. And background activity in DTPA is more compared to that of EC scan.
Excellent.
And
Very good. So DTPA is never done below the age of 2 years. It should preferably be avoided. Let me ask you, see, he has presented basically with infection. His urinary bladder is showing irregular bladder wall. Would you like to do an MCU first?
if the ureter is not dilated, then and some amount of if it is there, some amount of reflux is expected. So that won't change the management.
Okay, good.
No, I just want to know what is the meaning of changes of cystitis? There is a thickened bladder wall in a 11-year-old boy. So Siddhant, when you see like this,
Yes,
would
sir.
you like to do some investigation or would like to find out the cause?
So
He's not having any lower urinary tract symptoms.
So he has infection, definitely his frequency must be more. What else? But this is what the sonography is showing. And specifically mentioned that 5 millimeter, the thickness, the bladder thickness. So you will not do any investigation for that and you will sleep over that or you will do at least some investigation. Yes.
I would like
Pratik?
to see whether phimosis is there or not, sir. Phimosis can also lead to the bladder wall thickness and all.
Phimosis would lead to infection, and that ascending infection will go to the kidney.
We can do at least a PVR.
Yeah,
Wow.
that's what.
Yeah. One is PVR, correct. You're right. Then second, anything else? Is there any role of uroflowmetry in this? Non-invasive. Just say yes or no. Finish, and we'll go ahead. Yes, Siddhant.
So if the patient has no history of any instrumentation and no history of any LUTS, then uroflowmetry is not indicated, sir.
So just based on this investigation, you will not like to do it, correct?
Yes, sir.
So the next question, as Dr. Gyanendra has asked, will you like to do MCU?
Sir, MCU has certain indications if the patient is having any hydroureter or any scars on the kidney, and if the patient is having recurrent UTI episodes, in that case, I would like to do MCU, sir. Or if the patient is having only a solitary first episode of fever, and then, sir, I would not.
Okay. Fine. I think
Yes.
with all your combination, you people have answered quite well. So now
Yes.
next you want to do DTP renal scan, correct?
EC scan.
EC or a MAC 3, sir.
Okay. Yeah, it's MAC3. Okay. Harshu, show them. Any one of you can just comment on that?
So the first is the perfusion image, where the right kidney shows little reduced uptake compared to the left kidney, and the left kidney in the parenchymal images, the left kidney is draining with retention or hold up of contrast in the right kidney, and the Tmax is for the right is 14 and the left is 3.2. So it is more than 3 to 5 minutes.
So plus also there the graphs
And
on the right side, there is uprise curve and there is a continuous uprising curve. So it indicates
type 2 O'Reilly curves.
type 2 O'Reilly curve. And on the picturistic images, sir, there is hold up of tracer on the right side and there is prompt excretion on the left side. And sir, the split function is on the right side is 46 and on the left is 53.4. So T max is only 14, but that
That is T max. It is not T half.
yes, T half is,
T half
T
is
half
not
is not
mentioned
mentioned,
for
sir.
the right side.
Yes,
T half
sir.
is left side is 10.
yes, sir. T half max is not given on the right. So
this is an obstructed pattern, sir.
obstructed pattern on the right side, sir.
Fine. Yeah, all the observation is quite good. And also you can see that right kidney is quite hydronephrotic
Yes, sir.
compared to the left, correct? It is enlarged.
Yes, sir.
So now next what?
Quite interesting, na? Grossly hydronephrotic kidney, thinned out parenchyma, recent infection, and still it is showing 46.8% function.
So what is the reason behind this? G.R. Sharma has said surprisingly, why it is like that?
So it
Gross
is
hydronephrotic would show some increase, sir.
increase in the differential renal function, sir. So I would also like to counsel the parents regarding this that after the procedure is done, there would be no improvement in the differential renal function because it could be fallacious here because the system appears to be obstructed and it is grossly hydronephrotic with parenchymal thinning, sir. So based on these, the differential renal function that is given here is appears to be fallacious, sir. So that I would like to explain it to the parents, because after the surgical procedure is done, post-operatively, we need to compare it.
Okay.
Any of you aware of what is a cortical transit time?
The
Yes,
cortical
sir.
transit time, it is the time taken for the radio tracer to travel the cortex and reach the pelvic alveolar system, and it denotes the excreting capability of the system, and that is ideally a good marker to know whether the system is obstructed or no. If it is less than the cortical transit time, if it is less than 3 minutes, it is normal, or if it is more than 3 minutes, it indicates that the system is obstructed.
So in this case, what do you think is the cortical transit time on the left side and on the right side?
So right side it is normal. On the left side it is normal, sir. The right side it takes usually 5 minutes. So it is
Yeah.
more on the right side.
If you have that difficulty in answering, you are perfectly right, because they have given images which is from 1 to 4 minutes, then 7 to 12, and then from 13 to 18, or 1 to 6 and 7 to 12 and 13 to 18.
Yes,
So
sir.
ideally, if it would have been 1 minute images, then you would have been able to answer it much more accurately. But despite that, it is definitely more than 6 minutes on the right side.
Yes.
Yes, sir.
Yes. Okay. So what next?
So
I would,
now there are
Sir.
a couple of investigations which were done, which are not asked for. So Harshu, can you just show them? So the patient came with a CT scan. Any one of you can.
The
Now we
plain
already
NCC.
discussed. So when you will ask for a CT scan in children. Can you see the discrepancy between this and ultrasonography? Bhushan?
Yes, sir.
Yes, sir. The
Uh,
parenchyma here
yeah.
appears to be little bit better, not so much thinned out as compared which was seen on ultrasonography.
Exactly.
And the bladder wall is also significantly thickened.
Yes. Can there be two pathology? Or do you think that it is only because of infection?
So there can be two pathologies.
Like
You are associated with the PUJO, sir.
You are with PUJ.
why we are? There is no dilated ureter. There may be some sort of outlet obstruction. And there are chances which is of the very mild
There could
category. So
be.
that is why the child has not complained about that. Recently, I have come across two adults who have got this outlet obstruction, which was probably a congenital. And then when I asked them, they said, yes, when we were in school, we used to take a longer time compared to my friends when we used to pass urine. Harshu, we have done any other investigation?
Sir, we have a Euroflowmeter with us.
Just show them. Now, for a 11 years old boy, do you think there is a normal uroflowmetry? Okay, let us not divert ourselves. Let us go back. Harshu,
Yes, sir.
go to DTPA renal scan. Let us ask them how to treat this patient now. Yes, Bhushan, let us start from you.
Sir, as the cortical transit time is increased on the right side, along with the curve has been showing the type 2 only curves, so it is suggestive of obstructive system. So I would like to go ahead with the surgical correction for the PUJO, sir, this pyeloplasty, sir.
So whatever pyeloplasty you will do,
Sir,
whether you will do RGP, whether you will do degestenting earlier, or you will do at the same time, or you will not
uh,
do.
I would like to do before surgery. I would like to do the RGP, sir. No, like after doing the RGP, I will see whether the complete ureter is any another form of like narrowing is there in ureter or not. After confirmation of that, I will go ahead with the pyeloplasty, sir.
No, so Bhushan, I want to know whether you will do at the two different times. Number one, whether you like to do RGP or no. Second thing, will you like to put a DJ stand when you are doing RGP? And third, whether you'll do RGP and a pyeloplasty at the same sitting.
Uh, RGP and pyeloplasty at the same setting, sir.
Okay. Ankit, what is your choice?
Sir, I will do GP with dismember pyeloplasty, open dismember pyeloplasty, sir.
No, the question is whether you like to do RGP earlier, or you'll do RGP with DJ stanting earlier, or you want to do RGP and pyeloplasty at the same sitting.
Sir, I will do the RGP with pyeloplasty at the same setting.
Okay. Who else is there?
Sir, RGP and
Pratik?
pyeloplasty should be done at the same setting, sir, because it will help to know us whether there is any distal obstruction, UV junction obstruction, or it will tell us the distal ureteral patency, confirm the distal ureteral patency, and it also will, sir, help us to mark the incision after doing RGP. So, and after doing RGP, I would like to place a stent there, sir, so as to it will help me I would place a UC, so it will help me during pyeloplasty to identify the ureter and also help me for antegrade stenting, sir. So, but if we are doing
It will drain the pelvis.
Sir, I would like to keep it just below the PUJ because for antegrade stenting, sir, because sometimes what happens is after fidgeting with the uretrovesical, after doing RGP, there would be edema at the uretrovesical junction. So when placing the antegrade DJ stent, sometimes it coils in the ureter itself. So instead, I would like to place a wire or a UC so as to do an antegrade stenting. That would be.
Okay, so all of you are in the opinion that you will like to do cystoscopy, correct? And
Yes.
RGP and followed by pyeloplasty at the same time.
Yes.
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 Okay, what type of Pratik, and Samit, I want from you, what type
Yes.
of pyeloplasty you like to do?
So I would be preferable with open approach, open dismembered Anderson-Hines pyeloplasty, sir.
What do you mean by Anderson-Hines? Dismembered pyeloplasty.
Sir, we excise the spasmodic or the
So what are the
stenotic.
principles? Just tell me the principle.
So mucosa to mucosa, full thickness, watertight, tension-free, diamond or a funnel shape anastomosis over a stent.
Dependent, non-dependent?
Dependent.
Removal of redundant pelvis or not?
Yes.
Removal.
Then, and the last thing, if there is a obstructing vessel, then
Anastomosis anterior to the vessels.
Anterior.
Can one of you say all the things?
So the principle, it should be a widely patent mucosa to mucosa, tension-free, watertight, dependable, with excision of the redundant pelvis, and a DJ stent should be placed at the last. Anderson-Hines.
Anterior to the vessel.
Yeah. So which are the other pyeloplasty you know?
Sir, there are Their flap pyeloplasty is like spiral flap, sir, vertical flap,
So
intubated,
spiral, when you will do spiral.
So when there is a
so long segments, sir, long segment stricture, proximal ureteric stricture, sir, at that time, sir. Then
So
Foley's VY plasty when the high reading of the ureter, like insertion of the ureter is there at that time, sir.
and sir verticals cardinoprints when there is box shape extrarenal pelvis
So
or intubated uretero when there is a multiple strictures or a very long segment strictures.
sir,
So Sumit, today if there are multiple strictures, then what type of surgery you would like to do?
Multiple strictures in the proximal ureter, then the
Then
in
a ductal deviate spiral flap.
flap pyeloplasties.
If there is stricture in the proximal ureter and there are multiple strictures, I would like to do a spiral deviate pyeloplasty, sir.
Nowadays, everyone is doing buccal mucosa.
what is Hellstrom procedure?
Hellstrom procedure is done in the like lower vessel, sir. If it is crossing, so we will just push the pelvis away and the vessels downwards, sir, so that the kinking which is happening, it will not happen.
Yes. It is called as a vascular hitch procedure. So when laparoscopy came initially and robotic surgeries came initially, people were not so experienced in doing this dismemberment and anastomosis. So for vessel crossing, they would do an Hellstrom procedure. So the initial reports from the bigger robotic centers in the world, where they were doing these robotic pyeloplasties in adolescents and in young adults with a crossing vessel, they would always say ki, how good an Hellstrom procedure is. But later on, now with the expertise being available, most of them would agree that you have to dismember and then anastomose in front of the vessels.
Right. So which size DJ stent you will put?
This is 11-year-old male child, sir. So 11 plus 10, almost 20, like 20 centimeter, 4 French, 3 French or 4 French time, sir.
Siddhant, what is your view?
Yes, sir. 20 to 22 centimeters, sir. It is plus 10. So the length would be 22 centimeters and 4 French 22. 4 by 22, sir.
So 4 or 5, but definitely not 3. 3 is not going to be okay. Any one of you are in favor of putting nephrostomy? Or if you have already done a nephrostomy, can you avoid a DJ stent?
No, DJ stent, sir, should be placed because if a nephrostomy is placed, it will drain the ureter and drain the pelvic calcium system, and the anastomosis would be dry. We don't want it to be dry. For that, we would like to place a stent, sir, and we will clamp the PCN if it is already there. If it is not there, we would not put a PCN, sir. PCN would be only inserted if there is if there is infection or when the anastomosis is under tension, or whether if we are doing a procedure with a stone, if there is we are doing pyeloplasty with stone or a ureterocalicostomy, only those conditions we would like to place a PCN. If there is no infection, the tension is normal, the anastomosis is not under tension, would like to just place a DJ stent, sir.
Okay. Pankaj bhai, Gite sir, any other question or we have got another case also?
See, can I ask a question again?
Sure.
Yeah, please.
Yeah, thank you. So the message is you can go ahead with the corrective surgery on functional assessment by the renal scan and ultrasound.
Yes.
Okay.
In children.
In children, yeah. Okay.
In children. Okay. So can we go ahead with the second case? Harshu, show them the second case.
The second case is of a 51-year-old male presenting with chief complaint of left flank pain since 3 weeks associated with nausea and vomiting.
You tell the full story, history. Finish
Yes,
it
sir.
fast.
The patient was relatively asymptomatic 3 weeks ago, after which he developed pain in the left flank, which was gradual in onset and increased over time. Pain was dull aching with episodes of colicky, severe episodes in between, which subsided gradually. It radiates to the back. It gets better with rest, lying down, and pain medications. Pain is associated with nausea and occasional vomiting, especially during the severe episodes. There is no history of fever, dysuria, hematuria, lithuria, pyuria, burning, micturition, recurrent UTI, no LUTS features, no previous instrumentation or catheterization, and the past history is also not significant. Family history is non-contributory. There is no addiction. Patient is sexually active. On examination, the BMI is 35 kilogram per meter square, and otherwise the vitals is normal. On examination per abdomen, there is no significant finding other than the patient's being circumcised. Similarly, on palpation, also no significant findings are present. Rectal examination is also normal.
Yes. Now, just tell us what are the investigations you like to do?
So
Any one of you.
CBC, RFT, urine routine, along with an ultrasonography of KUB with post-void.
Why are people asking only KUB? Why not abdominal and pelvis?
Abdomen pelvis with post-void.
Because sometimes these people are like horse's eyes. They will just do KUB because the
Yes.
charges for KUB is less, and then for full abdomen, and then in that case we miss something.
Yes.
Many times I have seen. Okay, Harshu, show him all the investigations.
Everything looks okay.
Okay, next. Okay, next. So no growth. Yeah. Samit.
Yes, sir. So this is an ultrasonography of KUB. The bladder appears to be, an abdomen. The solid organ liver appears to be normal. The bladder appears to be well distended and looks normal. The right kidney appears to be normal without any hydronephrosis, maintain corticomedullary differentiation. And the left side, there is mild to moderate hydronephrosis, dilatation of the pelvis with callicial dilatation, maintained parenchymal thickness. The ureter is not seen, sir, not dilated, and no other, without any evidence of hyper echoic focus or a shadow or any stones.
Samit, just see from above, first, second, and third, the last fill, and the fourth one, first fill. Do you think there is something abnormality?
Next.
Like a cystic component.
Some in the
cystic component on the upper.
hypoechoic, some.
No, if there is little discrepancy between the upper pole and the lower pole, callisis.
Yes.
The upper pole is more dilated, something like that.
Yes.
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 So what I mean is, I also was not aware. But these are the small things which will help you in differentiating different conditions. Okay. So Siddharth, now next what you want to do?
Report.
So report.
So there is
Stone is
Will you like to see the sonography again, Samit?
yes.
Harshu, show them again.
It's very. It looks like in the lower pole, sir.
Okay. Harshu, show them the report. So it is saying there is a mild hydronephrosis and left-sided stone, right?
Yes.
So now what you want to do?
So then I would like to go ahead with a CT urography, sir.
Why just do sonography, stone is seen, go
Sir,
inside and
because
do the RIRS and remove the stone.
Sir, but about the dilatation and the
there is
ureter can't be traced, sir.
So this may be extra-renal pelvis.
Better anatomical detail and any other findings which are not seen on ultrasonography, which can be picked up on CTs.
Why? Okay. Harshu, show them. See carefully. Take 2 to 3 minutes. All 4 of you.
The contrast CT, CT urography, where the right sided system is normal, left sided in lower pole, a stone is seen, along with the no pelvic calcium dilatation because the contrast is not filled. Most probably can be parapelvic cyst, if at all it is.
on the upper.
See carefully.
Left side duplex.
Yes.
Yes.
Duplex moiety, the lower moiety is draining, the upper one is mostly not draining and hydronephrotic. And the upper one contains the stone.
Upper one or lower one?
So lower one.
Contains the stone in the upper one.
Okay. Show them the report. But see, on the left-hand side, if you see, in the earlier one, you will be able to see. Yes. See, I'll tell you which one. From above, the lower one, from left-hand side, the third one, second last one. See it very carefully. Again, can you see on the right-hand side?
Yes.
From above the second one.
The
Where
film
ureter is seen very nicely.
sir, the film aside of the Scott film, if you
Hmm.
observe that the dilated system of uh, upper moiety, there is no contrast inside the pelvic system. It is black. Looks,
Correct.
and
Yes.
exactly at the start of the PUJ, there is a ureter is clearly visualized in full length. So it will not happen until another there is contrast inside the system. That means this is a different ureter. That is the only clue for duplex system.
Perfect. I think this is a good explanation. Okay. Now see everything. You'll realize. Arshu, just show them the report. Just read it out. Impression.
There is developmental bifid left pelvic alysis system with single ureter. Left pelviureteric junction obstruction at superior moiety with web-like narrowing, with length of the narrowing not exceeding 2 mm, causing severe hydronephrosis of the superior moiety pelvic alysis system. Gravitational dependent left renal calculus in the mid-posterior calyx of superior moiety. There is left inferior moiety pelvic alysis system with no hydronephrosis or calculus. No right side calculus, no bilateral ureteric calculus or hydroureter. And otherwise, there is significant fatty liver, mild prostatomegaly, and urinary bladder is normal.
So now what do you want to do? Bhushan, Pratik, Siddhant, Ankit. Bhushan, what you would like to do? Come on, give answer.
Like, don't know the,
Just say what you want to do now.
like diuretic studies, like nephrogram.
Okay.
PPS.
Okay. Fine. Sure. Harshu, show them. Siddhant, can you comment on this? You are good at rhinogram.
Sir, the picturistic images shows that there is a prompt uptake on both the kidneys, sir, and there is hold up of contrast, hold up of the tracer on the left side on the images, uh, on the subsequent images. So there is prompt uptake, but there is hold up of contrast, and on the sir graph. Uh, Kidney left kidney shows a rapid up curve, and there is a rapid upsloping curve which suggestive of a obstructed system, sir. O'Reilly curve B on the left side, sir, and also yes, sir. And coming to the numerical value, sir, the GFR and differential function. So diuretic T half on the left side is not achieved, and on the right side it is 3.25. So it indicates an obstructed system on the left side, sir. And the GFR is the EC uptake on the left side is 146 and on the right is 105. So it is more on the left side. It could be fallacious, sir, or it could be because the lower moiety is draining properly. So it indicates a sir obstructed system on the left side, sir. So based on the graphs and the hold up of the transit on the left side, and also the T half is not achieved on the left side.
So now what do you want to do?
As the patient is having an obstructed system, I would like to counsel the patient and tell them that operative intervention would be needed.
But before operative, what is your final diagnosis?
left-sided obstructed system. So
Due to what?
PUJO obstruction, sir.
Obstruction of the upper mouth.
Or could be because of PUJO, sir.
So, what are we thinking about the duplex moiety now? What we suspected on the CT scan?
Lower moiety is taking up the contrast, upper moiety is not.
Not able to drain, the upper moiety is not able to drain the contrast. So yes,
If you see at the nephrographic the images, the kidney images were complete in the upper row, but in the lower row, the kidney complete silhouette is not seen. So the lower silhouette is completely drained. So
Yes.
the lower moiety has drained well, upper moiety has not drained.
yes, sir.
Okay. Even if you look at the CT scan images, it looks like a complete duplication. Okay. What Gite Sahib had shown was very, very correct that we do not see any contrast uptake in the upper moiety. But and in one image, you can see the ureter, which is white, means there is a contrast seen in the ureter. So that cannot come from a kidney which is poorly functioning. So that was the ureter of the lower moiety. Again, go back to the CT scan. Can you go back? Yeah, go back. Okay. Here on, say, the left side of the screen, if you look the second row, you can see the lower moiety is good in the second image. Can you see my cursor? I don't know whether you can see my cursor.
No.
Is there any way I can show it? So we can see the lower moiety with its ureter well, upper moiety is
Yes.
dilated. Okay. And probably these are complete duplication with a PU junction obstruction of the upper moiety. And this is very clearly seen in the DTP renogram because in the initial images, the complete renal silhouette is seen. But in the later image, you see only the upper half renal silhouette. That means the lower half has drained well, the upper half is still remaining.
Yes.
So my diagnosis in this patient will be left complete duplication with PU junction obstruction of the left upper moiety. What do you
With
think?
the with the stone, with the stone.
With a stone, with a stone, with a secondary stone.
So now, yes. So there is definitely, I think there was a single ureter lower down when it was entering into the bladder, if I'm not mistaken. And upper, there were duplex system. So now all of you tell me what you will like to do now. You have come to the diagnosis, Dr. Pankaj Maheshwari has given you a very beautiful diagnosis that there is a complete duplication of both the system with the pelvis and different ureters. Okay, and the upper system is obstructed, upper moiety with the stone. Now what you want to do?
So as it is an obstructed system, it will require surgical intervention. So I would like to counsel the patient, and as it also has a stone, I would so like to go for an open approach, open Anderson 9 spiroplasty, sir, of the upper moiety.
No, Siddhant, just tell me what are the challenges in this case compared to a simple single moiety PU junction obstruction? Like earlier case, when suppose there is no infection in earlier case, correct? It was a simple case, straightforward. Now, what are the challenges in this case?
Sir, if there is a single ureter and two moieties, so the anastomosis would be difficult because
No, upper moiety they said, na, there are two ureters in upper moiety. I mean, in upper part.
So what sir is saying is that there may be a Y junction lower down, but at least in the upper part, they look two different moieties.
yes.
Okay, now tell us both the ways. Suppose the Y is quite up. Then what are the challenges? And if Y is lower down, what are the challenges?
Sir, in such cases, first I would like to do a scopy and an RGP so as to delineate the whole pelvic elevation system in the ureters before. And sir, the affected system, I would like to put a ureteric catheter so as to identify during operative procedure just below the obstruction so as to just identify the ureter which is the system which is obstructed. And sir, the dissection would be difficult as sir, the dissection would be more difficult if both the ureters, if there is a bifid system and two ureters, so it would be the dissection would be difficult in such cases, sir. Whereas first I would like to do Anderson-Hines spiloplasty after putting a ureteric catheter on the upper moiety after confirming the affected ureter and the pelvic elevation system, sir.
So can I ask
You
a
are saying that
question?
there is.
Yes, sir.
Can I ask a question?
Yes.
I'm not.
Who is
Yes.
there? Yeah, but
I'm
ask
Dr.
me, sorry. Yeah.
Yeah. See, what was the purpose of doing a diuretic renal scan? Because I think we wanted to assess the functions of both the moieties, is it not?
Both, and if there is an obstruction or not.
Correct. So what is the conclusion now? Is the upper moiety non-functional?
No, you are able to see
MI is there.
the uptake.
So because the surgery would depend on the functional status of the upper moiety.
Yeah. So you see the DTP renal scan.
You are exactly right. But the assessment of the differential function of both the moiety is possible with the renal scan. If that particular moiety is suggesting the function, we are going for the corrective surgery. If that particular moiety is not showing any function, if it is less than 10%, then that particular moiety we have to remove it.
So, sir, what I also feel is that the cortex of the upper moiety looks fairly well preserved. So, very unlikely that it will be poorly functioning. And yes, if we inform the nuclear physicist well, they can do different ROM markings in the upper and lower moiety, and then they can give us the function of each moiety.
Correct.
Yes. So if you go to see the DTP renal scan which has been done, you will realize that upper moiety is functioning well and it is retaining.
True. And
so that
even
is why
the CT scan image, in one of the image in the say, left side
see
lower
on the right
panel,
hand side.
there is some
Side
contrast
from
seen in the
above.
upper pole.
Yeah, the whole kidney is showing the good uptake.
Yes, yes.
Kindly show the renogram again.
See on the right hand side, the lowermost is showing
It is showing function.
scan of the probably of the upper moiety only. The retained.
So the third row of images is only upper moiety.
Upper moiety.
The lower moiety is drained off.
Yeah. No, here we are justified to talk about that.
Even in this single image that is seen in the corner, there only upper half of one kidney is visible.
Yes.
Correct. So Bhushan, let us start from Bhushan. Bhushan, what would you like to do?
The upper moiety, open upper moiety and the science pyeloplasty only, sir.
And what about the stone?
Like yes, sir, stone removal along with the stone removal, yes, sir.
How will you remove the stone?
Sir, after opening the pelvis, we can use the flexible nephroscope and do the laser.
So you do
While
the laser, the sand will remain inside.
It's a very small stone. It can be picked up through the pilotomy.
Yes.
Okay.
And
So
second
Yes.
thing, don't
possible.
break the stone. If you break the stone, then this stent will remain inside. And when you do pyeloplasty, after that, it will come and get stuck there. It can cause fibrosis.
Okay.
I think
Fine.
a better treatment option or one of the treatment option will be to do a pylopilostomy in this patient. What do you feel, Dr. Gyanendra or Dr. Gita sir?
Sir, it depends on the RGP findings. If the
Yes.
RGP is showing a good, it's a complete duplex system, and then you can go for a straight away pyeloplasty.
Yes. Okay.
Yeah, if it's a complete duplex, but if it is an incomplete or a wide sort of a thing, then a pyloureterostomy or something would be needed.
Pylopilostomy, something like
Yes.
Or
that.
pylopilostomy. So
Yes.
if
Sir,
Pankaj, as
उसमें
you said
the
very rightly,
how much is the common sheath? That is very
yeah,
important.
exactly.
Page extrarenal
Yeah.
pelvis in both the sides. Then if it is totally two different pelvis and not a common sheath starting exactly from the PUJ, then one can go for pyeloplasty. That will be a better answer. If it is a common sheath very nearer to PUJ, then better to a pylopilostomy or pyloureterostomy. That's what I feel.
Yes,
True, sir.
sir. It all depends on the RGP. You're right.
Yes, that's true, sir.
Correct. So that is the answer. Fine. Anything else?
That's it.
That's
Wonderful,
it.
sir. This
Okay.
was a very good case.
Mm.
We have got other couple of cases like this, but we'll discuss later on. I think that we should now, next time, we should discuss about the scans. Can we call someone and discuss that? Gyanendra?
Yes, yes.
Yes, sir. बोला सकते हैं.
Fine. Okay. Then we'll do that. One session we'll keep for that, followed by some other case. Okay?
Yes, sir. Yes.
Yes, sir. Yes, sir.
Okay, sir.
Okay.
Good night, sir.
All the students are answering well. We are very happy. And today, 4 students have participated. It's a good news for all of us. Last year, we had lots of problems of asking, and there were only very few participants. So please keep it up. It is going to be of a great help to you, all of you. Thank you very much.
Thank you, sir. Thank you,
Yes,
sir.
sir. Thank you. Sir.
Thank you.
Good night.
Good night. Good night, Pankaj bhai. GR versus GR. Thank you very much.
Thank you, Dr.
Tanvi
Gaurang.
called me GRS, sir. Chaudhary, thank you very much.
Thank you, Dr. Gaurang bhai. Thank you.